Good morning, good afternoon, or good evening to everyone. Today we will discuss surgical interventions after facial paralysis. When they are indicated, when they are not indicated, and why. Our patients quite often ask us about various sorts of surgical interventions to help overcome the residuals and complications after long-standing facial palsy. That is another question which asks for discussion because, well, from our point of view, any surgical intervention should very seriously be considered for its pros and cons. Why? Because we all know that once the surgery has been performed, it cannot be undone. So this is more or less a one-way trip. And if the results are not as patient has expected, then you cannot do it, you cannot turn it back. So really important things to be considered. And that is the reason why we decided that it's the time that we discuss this very, very important matter so that you, our patients, or our future patients maybe, can have a lot of information so you can make your informed decisions whether to go for it, yes or no, and in which cases it may or may not be helpful in your particular situation. Let's discuss. We'll first address a couple of interventions that are possible during the acute phase of the facial paralysis. First one, Tarsorrhaphy. What is Tarsorrhaphy? Tarsorrhaphy is just sewing together the corner of the affected eye so that it doesn't dry out. So the cornea doesn't get dry. So it is easier to close the eye with the eye patch, for example, and that is applicable during the acute stages of the facial palsy when it is important to protect the eye, to preserve its function, and to avoid complications related to the eye, to the fact that during facial palsy, the eye becomes dry, the tear production is pretty much reduced, if not interrupted altogether. So it's important. Well, it is disputable whether this operation is always indicated. Quite often, the moist chamber, which can be just glued with the stickers to your eye socket, can offer a solution. Just regular eye patch could also be an alternative. And of course, ointment or artificial tears can also solve the issue of dry eye. So whether Tarsorrhaphy is indicated, it's a big question. And also from our experience, and we have seen quite a lot of patients, this operation is not very often performed anymore. There was a time, 20, 30 years ago, it was more popular, more often performed, but not anymore. Another option to improve the closure of the upper eyelid is insertion of the golden or platinum weight. By the idea, by its weight, it helps to close the eye, and at a certain moment when there is no more need for that and the eye begins to close better, it is removable. This option is not used very often nowadays. It does have some applications. Whether it is efficient or not, again, from our point of view, it still has to be considered very much. Why? Because on one hand, when the weight is pushing down, it helps to close the eye. On the other hand, to open the eyelid, you need a much higher effort from the levator palpebrae superioris, from the little muscle that opens the eyelid, which means that that muscle becomes more active, more involved in the opening, which means it will be, even when its resistance by the weight is higher, then the muscle will be even more difficult to relax and to stretch. So this is, on one hand, it does help. On the other hand, there is a risk that it will strengthen the very muscle which is standing your eye closure or the blinking in the way by resisting the effort to close the eyelid. Another one, all the others surgical interventions, they are more related to the later stages of recovery when residual effects and complications start to be visible and noticeable. And another one is blepharoplasty, which means that the upper or sometimes also lower eyelid being surgically affected, so that either the eye becomes larger, or visually larger, or smaller. Whether blepharoplasty is indicated immediately after, let's say, 3-4 months or 5 months, even a year since the onset of facial palsy, it's also a question of big discussion, because from our point of view, it is not necessary except for the very few extreme cases. The thing is that the irregularities in the closure of the eye and visibly smaller eye fissure, they are related not so much to the physical or anatomical differences between the affected side and the healthy side, but rather to the function of the one particular muscle, and that is the muscle that is called levator palpebrae superioris. That is the muscle that lifts the upper eyelid. What is special about that muscle and why it deserves special attention? The thing is that although this muscle serves the eyelid, so closure and opening the eyelid, it does not belong to the facial nerve. This little muscle that opens the eyelid belongs to the different nerve. It is the number 3 cranial nerve, nervus oculomotoris. Actually, it's the nerve that provides our eyeballs for the movements. So that muscle that opens the upper eyelid is connected through this particular nerve. And to illustrate that, you can make a very simple experiment. Just with your head steady, try to look down and ahead, down and ahead. And you will see that your eyelid goes down very easily without any effort from your side. And for those of you who have seen kinesis, which means when the eye, together with the blinking or closure of the eye, the mouth corner moves together, this in kinesis will not be present. This is a very simple illustration, just to let you observe that when the signal is directed through the different path, in this case, the path of the 3rd cranial nerve, the upper eyelid goes down quite normally because the eyelid receives proper, undistorted relaxation signal, and it just goes down by its own weight. So this is another reason why we think that doing blepharoplasty, except for, again, extreme cases, is very seldom indicated for the, let's say, regular facial palsy, which is usually called Bell's palsy. Then next, another intervention which used to be quite popular some years ago is the muscle transposition. And this is the surgical intervention when the temporal muscle, the flap of the temporal muscle, is taken, reversed, and connected to the mouth corner, and then the affected mouth corner would go up in a sort of imitated smile when the person clenches the teeth, so makes a chewing movement. Then together with that, let's say, imagined chewing movement, the mouth corner will go in the direction of, let's say, imitated smile, like this. That is, of course, only on one side. From our experience, this operation is indicated only in the cases when it's absolutely certain that the facial nerve, at least its zygomatic branch, which connects the brain with the muscle that provides for the smile, is absolutely 100% for sure dead when it's inoperative. And that happens really, really seldom because after, let's say, regular facial palsy, Bell's palsy, or Ramsay-Hunt syndrome, or any other, let's say, non-surgical injuries to the facial nerve, it is extremely seldom that any of the branches, for that matter, becomes irreversibly damaged. The cases when this operation may be indicated is only when, due to certain, for example, tumors of the parotid gland. If the parotid gland had to be removed, and with that operation, the respective zygomatic branch had to be cut through, then, of course, that branch of the nerve is irreversibly damaged, injured, and then one may consider this intervention, because otherwise the mouth corner will be completely motionless, because there are no signals that can pass through the permanently severed nerve branch. So, but we have to really be realistic in our expectations, because let's put it straight, this is rather radical intervention, and it's a part of a muscle which is about that wide, let's say several millimeters wide, 5-6 millimeters wide, which are just sewn to the mouth corner physically. Just so here you will be a little bulge here, and it's not necessarily that it will work perfectly as we may expect or may be promised. It is rather sensitive matter, and I do suggest that you very seriously consider, read all possible sources if possible, talk to people who have had this experience, and before you really let this happen, you think twice, thrice, 4 times, 5 times, 10 times, and really consider whether it is your very last resort or not. So this is really something which I do suggest that you consider very seriously before giving it a final go-ahead, because as I mentioned in the beginning of this recording, surgical interventions is the one-way street. Once you do it, it cannot be undone, even if the expectations are not met by the results. Next option for the surgical intervention is nerve graft. What is a nerve graft? Nerve graft is an operation when part of your nerve is being taken from your leg, lower leg, and then your healthy side is being connected to your affected side, like this. We have to realize, however, that to do this operation, 2 important things has to be done. First, this nerve graft with its end at the affected side must be connected to the part of the nerve which is attached to your muscles that provide for the smile. But to do that, we need to cut off the root part, so-called proximal part of that particular nerve branch, which means that it will be we will actually be killing or irreversibly cutting through the nerve branch. So the signals from the brain that are created in the direction of this area will be irreversibly lost, and the signals that will be available, those are the signals that will be produced on the healthy side to travel all the way through here and then reach the affected side. We need to remark here, however, that when you cut the piece of the nerve, it doesn't mean that it's like a wire. You cut the wire, you attach it to one end and the other end, and it starts working. It's not the case in the nerve with the nerve, because when you cut the nerve out of the leg, everything what is inside dies. So what is necessary is that when that part of the nerve, little piece of the nerve, is attached to your, let's say, healthy side nerve, the fibers which are driven, which are diverted inside that graft, have to grow all the way from one side to the other, to the connection point, and then grow back inside those tubes or bundles of nerve fibers that are connecting it to the respective facial muscle. It's a long way to go. It is minimum 15 to 20 centimeters to grow through, and then another 5 to 6 centimeters to go from the connection point to the nerves. And underway, there is a fair chance, quite a big one in my opinion, that a great part of the nerve fiber that started to travel from here all the way to the opposite side may stop halfway and will never reach their expected target muscles. That's number one. Number two, it's an extremely long process because, as you may find in the scientific publications, it has been researched somewhere some time ago that under the best possible circumstances, the speed of nerve fiber growth is not more than 1 millimeter per day under the best possible conditions, which means that if the nerve fiber has to grow about 20, 22, 24 centimeters in order to reach your muscles, is 200 to 240 millimeters, which means 240 days of waiting. And that is almost 9 months, if my math is correct. And then there is a fair chance that considerable part of those nerve fibers that are growing will not reach their destination muscles, which means that again the efficiency of the nerve graft is not always as expected, and in our opinion here in the clinic, it is again indicated in those cases only when there is absolutely certain that the original nerve trunk has been irreversibly damaged, injured, and there is no more connection at all between the brain and the affected side muscles through its own facial nerve. So that's another thing. And coming to that, the next less invasive but still invasive surgical intervention is selective neurolysis. What is selective neurolysis? Neurolysis, actually, lysis is destruction. Neurolysis is destruction of the nerve. Selective neurolysis is selective destruction of the nerve. What does that mean? Selective neurolysis is mainly being indicated or is being suggested in the cases when the patient is experiencing synkinesis. What is synkinesis? Probably you read already. If not, visit just general internet or our website or our other YouTube publications to get deeper into this question. Synkinesis is involuntary contraction of certain facial muscles which normally do not belong to the intended facial movement. For example, when we blink the eye or close the eye, the mouth corner moves involuntarily. Or when we blow the cheeks, the eye would involuntarily close, or the fissure in any case would narrow. This is synkinesis. Or sometimes when with the facial movements, the neck becomes very tight, or when we make a big smile or even a medium-sized smile, the mouth corner remains stationary because of the counteraction of antagonistic muscle, which is here, it's muscle that pulls down the mouth corner. So the selective neurolysis, what it does, actually, it cross-sects, actually, the knife of the surgeon would cross-sect some, not all, some of the nerve fibers of the facial nerve that provide signals from the brain to the unwanted, let's say, muscle. In most cases, it is the muscle that is called depressor anguli oris, the muscle that pulls down the mouth corner. And that is actually the muscle that stands our smile in a way when the patient is confronted with complications after long-standing facial palsy. In those cases, although and it goes most of the time with a medium or large size smile, smaller smile, light smile goes most of the time without trouble or without much trouble in any case, but the larger smile really presents big difficulties and leads to a lot of frustration on the patient's side. So in order to reduce the resistance of the depressor anguli oris muscle, which involuntarily contracts together with our attempt to smile. So if in this case, let's say zygomatic major muscle would try to pull up the mouth corner, and the one which I mentioned before, the levator depressor anguli oris muscle, would try to pull it down. One pulls up, another pulls down, conflict of interest, and despite all the efforts and all the attempts of the patient to, I want to smile, the result is very insignificant, because the efforts of one muscle are being compensated by the efforts of the other. So that's selective neurolysis would cut through some of the fibers of the facial nerve that provide signals from the brain to this, let's say, unwanted muscle. Yeah, that's why its resistance becomes less, because less signals are coming through. So not all the fibers of that muscle are engaged, because some of them just cannot hear the brain. So the results are that the most of the cases, the smile gets better. Whether to go for it, yes or no, it's totally up to you, and that depends on your preferences and your expectations, on your possibilities, on your reservations for the surgery. We have to realize, however, that this particular intervention, although it's minimal, it's not that dramatic, it irreversibly, again, cuts through part of your facial nerve, and that particular area becomes partly denervated, which can give or cannot maybe give a desired result, or not as much as you would expect. Of course, everything is in balance, and this is something which I do encourage you to read as much as possible about, to consider all the options and make up your mind. And non-surgical but still a little invasive intervention is botulinum toxin or chemodenervation. What does it mean? It means that the nerve is being affected by chemical substances, in this case botulinum toxin, which has a commercial name, Botox, Dysport, or some other commercial names, but the core substance is botulinum toxin, which is a poisonous substance, which is being produced by Clostridium botulinum. It's a bacteria which resides in the rotten meat. That's why botulinum toxin, which in the free translation means sausage poison. But it's apart from its efficiency. It does work. It is efficient, and it is not permanent, which means that the injections of botulinum toxin, they again make partial denervation, hemodenervation of your some of the muscles where it is injected, and the signals, still unchanged signals coming from the brain, have less chance to reach the muscle. So then, of course, the unwanted contractions of the facial muscles, synkinetic contractions, become less pronounced, less visible, and bring some positive aesthetic effect. However, we have to realize, and it's being said upfront, this is not permanent. So the botulinum toxin effect remains 2, 3, 4, 5, sometimes in some extreme situations up to 6 months, and then the effect subsides, and the patient has to consider whether to repeat it or to look for something else. So this is something which I would like to discuss with you, at least in general lines, to give you an idea which invasive interventions are available at this moment. I didn't mention another one, facial nerve decompression, which means that within the first 2 months after the onset of facial palsy, here certain surgical intervention is being done. They open here this bone here behind the ear to decompress the facial nerve. But in the last decade, last 10 years, I didn't hear really much about application of that particular intervention because there were no evidence that it does have any positive effect statistically. And I would agree with that because when the damage to the nerve has happened, and it does happen within first 3, 4, maximum 5 days, then it's too late to decompress anything because the nerve has already sustained damage and degeneration has already taken place. So 2 months after the event, trying to remove the cause is a little bit on the later side of the application. So this is what I wanted to share with you today. Please take the time to invest some time to read more about the facial palsy, Bell's palsy, about what helps, what doesn't, what to expect, what could be the prospects of your recovery after the onset of the palsy, which options are available. If you want to, do register for an online diagnostic session, if that is what you want to do. And in general, I wish you to recover very soon. If you already have confronted some of the complications and residuals, I do wish you to overcome those with the most efficient, in the most efficient way, as soon as possible. And if you think that we can help you, or at least if you want our advice about your situation, don't hesitate, write to us, and we will do our best to help you. Thank you.